So the today's topic is adjuvant treatment of CA colon. So we have Dr. Senthil today with us. He can help us in sorting out the issues that were raised yesterday. He can give his comments also. So starting, uh, so we know the aim of postoperative chemotherapy is to destroy the microscopic metastasis and reduce the risk of recurrence. So adjuvant chemotherapy for stage 3 colon cancer is well known, and it has been shown to improve PFS and OS and is recommended as standard therapy. But the value of adjuvant chemotherapy for patients with stage 2 disease remains controversial and it's a gray area. So if we look at the adjuvant chemotherapy in colorectal cancer, the evolution since the inception of IFU, since it was discovered, we have not made much progress in terms because the backbone still remains the 5FU. We have added other drugs to it, but still 5FU remains the backbone. Then the question arises, who should receive the adjuvant chemotherapy? So if we look at the Accent database of about 21,000 patients who were treated in the adjuvant setting in the stage 2 and the stage 3 patients, though we can see the margin of benefit was probably the same, the magnitude of benefit, but it was not statistically significant for stage 2 patients, while it was statistically significant for the patient with the stage 3 disease. So if we look at the NCCN guidelines, so whom we should be treating with adjuvant chemotherapy? Clearly, stage 3, no doubt, yes, we should be treating. Stage 1, clear, yes, we should not be treating, no treatment for stage 1 disease. And stage 2, MSI high, we need to, the treatment is observation. But there is one MSI high with high risk features that we need to discuss and debate. Then T3N0, again, this low risk, no high risk features, but sometimes what are the options for the MSS stable patients and high risk stage 2 disease, we will discuss. So if we look at the substaging of AJCC stage 2, stage 3 cancer patients, we can see as the stage increases, our 5-year survival decreases. So in fact, the survival for stage node positive patient and T4 subset is likely to do bad as compared to T3 but still node positive patients. So data for adjuvant chemotherapy for stage 3 colon cancer, the oxaliplatin based chemotherapy is the standard adjuvant for stage 3 colon cancer. The options include FOLFOX or CAPOX. Then 5FU alone monotherapy can be considered who cannot tolerate more aggressive oxaliplatin based regimes. So FOLFOX where here we can see clearly in mosaic data. In stage 3 patients, the hazard ratio was 0.8 and p-value was significant, showing some benefit. But stage 2, it was not statistically significant. So another study which showed Xelox improved DFS in stage 3. 3-year DFS was to the tune of approximately 70.9% with Xelox and 66.5% with 5FU fluorosil. It establishes alternatives to infusional therapy regime. So in patients who were not able to be treated with aggressive regimes, capecitabine monotherapy can be given as adjuvant treatment in stage 3. So coming to the other question, the duration of the treatment. So this was addressed recently, 2017, IDEA first published this. So in patients with stage 3 colon cancer receiving FOLFOX or CAPOX, 3 months versus 6 months was said to be equivalent, and patients were treated with CAPOX. 3 months of therapy was as effective as 6 months. But so adjuvant therapy is indicated for node positive colorectal cancer. FOLFOX or CAPOX both are standard options. Capecitabine or infusional 5-FU leucovorin as option for some of the patients with comorbidities not likely to tolerate oxaliplatin-based regimes. And for patients who are more than 70 years, there is a uh, whether what is the added benefit of adding oxaliplatin to the regimes. So antibodies like biologicals are not indicated. The decision for adjuvant chemotherapy is subject to individual consideration. So coming to the gray area, adjuvant chemotherapy for the stage 2 colon cancer. So which stage 2 cancer, colon cancer patient should be treated with adjuvant therapy? We know 75 to 80% in this subset can be cured with surgery alone. Benefit of chemotherapy is small and there is no consensus whom to treat or how to identify and whom to treat, not to treat. So decision
डिस्क्रिप्शन का देखिए
to
सर है।
give chemotherapy based on clinico-pathological markers of risk, that is MSI, molecular biomarkers, the clinical parameters like LVI, PNI, obstruction, perforation, and it is not informative for majority of patients also. So if we look at the clinico-pathological definition of high-risk stage 2, so basically, most of the guidelines have compiled this. T4 is considered as high risk. Inadequate lymph node sampling, 12 by most, and ASCO says 30, less than 13 is inadequate. Poorly differentiated tumors that are not MSI high, bowel perforation, lymphovascular invasion, perineural invasion, and additional high risk features include bowel perforation and positive surgical MSI as such is a favorable prognostic marker in the treatment of colon cancer. And in MMR deficient patients, the recurrence was much less as compared to those with the MMR proficient patients. So this is an emerging biomarkers. We do not know their role as yet in deciding about the treatment in stage 2. One is KRAS, the other is the BRAF. So at this point of time, they are not ready for the prime time in the adjuvant setting, in the clinical setting. So for focus on the high risk stage 2, last year in ASCO, at ASCO 2019, the ASCO had presented data whether the same thing can, the treatment can be effective in high risk stage 2 disease. So they have done a pre-planned analysis and they had 3,273 patients with high risk stage 2 disease. So again, it was a prospective pooled analysis of 4 randomized trials investigating the duration of adjuvant oxaliplatin based therapy 3 versus 6 in high risk stage 2. So idea there they were these were the centers where the studies were done, and the rationale was in the exploratory subgroup analysis of the mosaic trial, the estimate effect of adding oxaliplatin to 5-FU in high risk stage 2 patient was to increase the 5-year DFS and overall survival from 83 to 0.3 to 1.8 to 85%. So IDEA showed non-inferiority for low-risk stage 3 colon cancer treated with 3 months of capox, but at the same time, oxaliplatin is associated with cumulative dose neurotoxicity, which was dose dependent. It was approximately to tune of 12.5% as compared to 6 months of follow. So study so the high risk stage 2 patients were randomized to 3 months versus 6 months, and Folfox or Capox were decided by the investigator. It was the investigator's choice. The same parameters they used to define the high risk stage 2 disease. So the studies were well balanced, but there was inequality in the studies, in the regime used, because it was the investigator's choice. The Scott had 12% of rectal cancer patients, rest all had 1.5% of rectal cancer.
Hello?
Yes, sir, we can hear you, sir.
Yes, sir.
Yes, okay.
So your screen is not visible, sir.
Sumit, you have to unmute yourself.
So this is the chart showing the neurotoxicity,
So your screen is not visible, sir.
not visible.
Slide is not visible, sir.
I think you need
Ye-
to screen share again.
Yes. Okay, sir.
So this is the chart showing the neurotoxicity results and the diarrhea results. So if we look at the modified intent to treat patients, the duration of treatment, the hazard ratio had crossed 1.12 levels, which was prescribed, and it was 1.17, and the confidence interval had crossed that limit. So non-inferiority value was 0.38. So since it had crossed, so they could not say whether 6 months is better or 3 months is better. So they were overlapping results. So if we'll compare by regime, DFS, we compare by regime, Capox, the curves are almost overlapping, so no difference there. But if we look at the Folfox regime, 3 months versus 6 months, there was a difference of approximately 7%. So concluding from this, they concluded that overall non-inferiority was not shown for 3 months treatment for high-risk stage 2 disease. So 3 months treatment resulted in significantly less toxicity, though the similar regime effect was seen as in stage 3 disease. So they strongly suggest non-inferiority for 3 months of Capox versus 6 months of Capox, but they suggest inferiority for 3 months of Folpox. So we have to use Capox, maybe 3 months is sufficient, but for Folpox, we need to give for 6 months. But so stage two, is that an important question? Yes, probably it is, because if we look at the toxicity consideration and the economic consideration, there is a huge difference. So toxicity neurologically, it is 2 to 3 times lower if we reduce the duration, and diarrhea is much better. Mucositis is approximately 2 times lower, and Hanford syndrome is 2 to 3 times lower. And economically, definitely, it is much economic for the countries also. So the idea recommends for the lower risk subgroup population, that is T3N1, 3 months of Capox probably is okay. But if we want to give Polpox, probably 6 months is what we should be giving. For high risk population, which is T4 or N2 group, we should, if planning to give, we should be giving 6 months of Polpox regime. So idea was not able to compare between Capox and the Folfox regime. So if we are using Capox, 3 months treatment probably is sufficient. Efficacy is as good as 6 months with significantly less toxicity than with the 6 months treatment. But if we are using Folfox 6, better, probably it is better than 3 months, and but at the cost of toxicity. The patient should be considered for adjuvant therapy, especially those at high risk. Approximately 30% of the patients with stage 2 currently receive adjuvant chemotherapy. We need to consider their comorbid conditions and overall performance status and other factors before going for chemotherapy. And we need to discuss with them before proceeding for therapy. Definitely, we need to improve our selection of patients. Then there is another important pertinent question between the timing. This was also discussed, brought out yesterday. So if there is delay, so does it affect the survival? Yes, it does. So usually every 4 week increase leads to decrease in the survival, and beyond 12 weeks, we do not know whether it is not recommended to start the adjuvant therapy if there is delay beyond 12 weeks. And definitely the survival decreases if the duration of treatment increases. So adjuvant chemotherapy in colon cancer. So as we age, the right sided tumor increases, and the nodes, their uh, nodes usually it's the same. More less of them are node positive. Here, so take home messages. Adjuvant fluoropyrimidine based chemotherapy improves survival in stage 3 and high risk stage 2 colorectal cancer. Choice of chemotherapy and duration of treatment should also take into account the magnitude of benefit and associated toxicity. Probably for low risk patient T1 to T3 N1, 3 months of treatment is enough. But the patients who are at higher risk, like T4 or N2 disease, may need 6 months of treatment. Overall, 5-FU leucovorin as adjuvant therapy appears to benefit all the patients with high risk colorectal cancer, but the benefit for addition of oxali in patients above 70 years of age is much less consistent. Thank you.